session. I'm Dr. Roxana Cruz. I'm the Director of Medical and Clinical Affairs at the Texas Association of Community Health Centers, or TAC. I'm pleased to moderate our opening panel, On the Ground Perspectives from Texas Primary Care Settings. Our panelists will provide perspectives from 4 clinic settings on the work of addressing patient social needs and what clinics need in order to advance their work. Each panelist represents an organization that was featured in the case study series that was shared prior to our meeting today. You may want to have that document handy during this panel just for reference, and you can find it attached to the meeting invitation. Each will say a few words about the work that they're doing, but will focus their remarks on one or both of the following prompts. First, what are the major opportunities and challenges to addressing social needs that can be found in the primary care setting? Second, what systems level changes are needed to support clinics in addressing their patients' social needs? Before introducing the panelists, just a quick reminder on how the panels will work. Everyone other than the panelists and myself should have their video off at this time. Each panelist will have approximately 8 minutes to speak. There will not be any slides. And after all 4 share their prepared remarks, I'll take questions from the audience. If you would like to ask a question, please raise your hand. And to raise your hand, as a reminder, open the participant panel by clicking on the participants button at the bottom of your Zoom screen, and then click on your name and you'll see a symbol to raise your hand. At any time during the meeting, you can submit information, comments, or questions through the chat box to the meeting host. If you have technical issues, send a chat and someone will try to help you out. So now it is my privilege to introduce our 4 panelists. As Dr. Lakey mentioned, we're keeping introductions brief so we can have plenty of time for conversation and discussion. But know that we are very fortunate to have each of these extremely well-qualified panelists join us this afternoon. So first, Penny Pabst, the Chief Administrative Officer of the Stephen F. Austin Community Health Network, serving Brazoria, Galveston, and Southwest Harris counties. Second, Celeste Harrison, the Chief Executive Officer of MEHOP, or Matagorda Episcopal Health Outreach Program, serving Matagorda and Wharton counties. Dr. Valerie Smith, a pediatrician and the Community-Centered Health Home Director at the St. Paul Children's Clinic in Tyler, Texas. And Keegan Warren Clem, Managing Attorney for Medical Legal Partnerships at the Texas Legal Services Center and the People's Community Clinic in Austin. So thank you. And we'll start with Penny Pabst. You're muted. Let's see.
There we go. Thank you.
Thank you.
So I did submit my case study, and we do participate in a network, the Signify Health Network in Brazoria County. And so a challenge that's really important is to ensure that everybody in the center is submitting screens. We use the Prepare screen, and that everybody is submitting screens and making referrals into our network. This is something that is done, we run reports weekly. I submit the reports, keeping everybody on their toes, so it goes to our executive team, the managers, and the staff that are supposed to be making the screens and running the referrals through the network on a weekly basis. This way, it's ensuring that the referrals are going out. I also look to ensure that we are responding to the referrals that come to us from our community partner organizations. We have 38 community organizations that are part of our network, because we did join with the United Way of Brazoria County to participate in a network of organizations to ensure that when we screen using the Prepare screen and our EHR, there are other organizations using the Health Lead screen in their social service organization systems, that we are responding to the referrals. So we want to make sure that we're meeting the patient's needs, and they have 3 days as an accountable system. So that's something that's really critical to us. Something else that's something that's really important that I see as a challenge for us is ensuring that we are meeting the needs of our patients in the other counties. Galveston County, where we don't yet have a partner, in Harris County, we have been contacted by Harris County Public Health, who's interested in looking to connect with us. So that's really great. Something that has been a big challenge for us lately is the COVID-19 crisis, of course, the pandemic, and it's placed a huge burden on the food pantry. We are one of the the two big food pantries in our area. We are one of the biggest contributors to them. We refer a huge number of our patients to the food pantries, and they've lost a lot of their volunteers. And that is something, well, they've lost a lot of volunteers because of COVID-19. A great number of them are seniors, and those people that are most vulnerable, and that's been a challenge for them. So they're having a struggle entering all the information into the system, which is something Dr. Gottlieb suggested. Another thing is many of those organizations, the others have had trouble through the pandemic to respond to the referrals as she suggested. Key features I want to also share that's critical is that leadership has to be 100% behind the program. If you're going to screen, you need to make sure, if you're going to do this, if it's a project for a community health center, it's critical that everybody is behind it from the top down. And our CEO is totally behind it, and it's been a success here. It's a success because our chronic care coordinators and our eligibility staff are doing it, and we get about 35 to 40 from our eligibility staff, and our chronic care staff are monitoring their patients. We haven't been able to get it to be successful in the clinic area, mainly because of COVID-19, but we need to go forward and add it as part of our job descriptions and make a policy. What has changed since I know I only have a few minutes, we did implement an interface between our EHR and the network that went live last week. So that has cut down on the amount of double work. As soon as the prepare screen is filled out in our EHR system, it sends the needs and the demographic into the Signify Health system. Then as soon as we authorize the patient through email or text, because patients aren't coming in to see us, there's a lot of virtual going on, then they can send the referrals to our collaborating partners, and that has cut down huge. I don't know what my time is, Dr. Cruz. Am I over?
You're okay. You're okay. You have a couple more minutes, 2 more minutes.
Great, perfect. So that has really simplified the process so that we are, that was the big drawback. It has made it so much easier. It's really brought a lot of buy-in to our staff using the system. And that way we can capture all the data in the network for how many screens and referrals, and the data is essential to drive our network. That is something that is important. We want to capture so we can really determine what our needs are in the community, and that is our goal. I know Dr. Gottlieb talked about it. For our community system, we want to be able to take to the local legislatures what it is, what is the need in the community, so we can drive home the message that there is a true need for whatever it is. We thought it was transportation. Transportation is not a need. That's what we've determined, if everybody is putting the needs in. But we know not everybody is, and that's another challenge in the community, is that we are having trouble from those partners who are crippled by the COVID. So we're collecting data. It's essential. It's really critical on the internal and the external.
Thank you.
Thank you.
Thank you so much. If we can then move to Celeste Harrison from MEHOP. Thank you.
Good afternoon. It's a pleasure to speak with you today. We are not nearly as organized or as structured or integrated as Penny indicated as they are at their clinic. Our integration really has occurred because of our intense participation within the communities since we started some 20 years ago. Our opportunities are bountiful. We're located in both Matagorda and Wharton being rural counties. So we partner and work with every nonprofit that is available, but they have very limited means. They're often, if you will, I'll describe them as a mom and pop soup kitchen. So we have a mom and pop soup kitchen in Palacios feeding people, one down in our other southern region of Sargent. Our greatest opportunity during, and I couldn't help but laugh when Penny called it the COVID, that's kind of how we look at it as well. But when COVID-19 hit us, we looked at our administrative staff, and all of our outreach workers, the entire team, was working from home, as many still are today, at least in some aspect. We engaged all of our team for chronic care patients to call every single one of them, find out what their needs were. So even though we haven't integrated into an IT system, we have met with every single one of our chronic care patients, determined their needs, determined if we could do a telehealth visit, and also worked with them to work with other social service networks in the community, depending on what their needs were. In contrast to Penny, we do know that transportation is a very crucial need in our area. We offer free transportation for all patients coming to our clinics, whether in Wharton, Bay City, or in Palacios. I think the greatest opportunity, and ironically, I think COVID, Elena talked about transformation of our systems, and I do believe that will occur because of COVID-19. For the first time, for whatever reason, our rural communities, there had been a tremendous amount of pushback at the official level, whether they be county or city, to really identifying that there were problems in the community and that individuals really had healthcare needs beyond what perhaps MEHOP as an FQ or the local hospital or local physicians could provide. But COVID has really created a system where there's realization that we're all in it together. And for example, we're told today that there's an outbreak of COVID in our city, at our city government level, as well as into our nursing homes. And I'm sure that's going to reveal characteristics of what we really need to do as far as all working together, whether it's wearing masks or whether it's taking all those social distancing practices. So, you know, every time there's a really awful thing, there are often bright moments. And I think that bright moment is the realization that we do have issues in our community and that we do need to work together to make them happen. I don't know that we'll ever, just due to the rural nature of our community, be able to integrate all of that into our IT system, so that it has that natural follow through that we're so used to as far as healthcare, where we put something in the system and we track it and we have immediate feedback. Well, when you're working with someone that's still on pen and paper, it's going to be real difficult to have that feed directly back into the system. Although we would love it, you know, I think there's always going to be those challenges for us. So in general, I think that's where we are. We make every opportunity to look to make improvements. We're incredibly successful recently with giving our chronic care patients all that they need to really improve and to keep their conditions at least where they were or better since the COVID crisis.
Thank you so much, Celeste. Moving then to Dr. Valerie Smith from St. Paul Children's Clinic in Tyler.
Thanks so much, Roxana. So I think St. Paul's is a unique place. I've had the opportunity to serve there for the last 14 years, in that we actually started as a social services organization. Before we had a medical clinic or a dental clinic or a counselor, we had a food pantry and a clothes closet. And so helping address and meet the material needs of our patients has been really integral to what we do, really even before, again, the clinic existed. But we've had the opportunity over the last 3 years to really dig very deeply in how we were addressing those social determinants of health, and what we wanted to track and where we wanted those outcomes. And really a huge part of that is due to the fact that we have been able to participate in an initiative of the Episcopal Health Foundation called the Community Centered Health Home that really challenges us both to address those needs on an individual basis, but also to work in the community. And we all know, I mean, if COVID has taught people within healthcare anything about the healthcare system, we know how to write policies and procedures now, right? And we know even how to think about process change. But one of the things that I think has been really critical to the success that our organization has had and the commitment to the work that our organization has been some of the internal work related to culture shift within our organization. And I think any healthcare organization that's thinking about how do we start to address these things really needs to think not just about what does that process, what does that flow sheet look like, how are we tracking it in the EMR. Those are all really important things, but really how do our staff know and understand social determinants of health and poverty and the patient and the issues that the patients we're seeing are dealing with. So we, over the past several years, have gone through a staff training initiative that included both training on poverty. Our entire staff did a program called Bridges Out of Poverty. And then we also, our staff went through trauma-informed care training. And then we started monthly staff lunches where we either focus on a specific social determinant of health and really how the connections between that determinant, whether it's food insecurity or housing instability and health outcomes, or we have a partner, this is unfortunately had to pause shortly because of COVID, but we have a partner come in from one of the agencies or organizations in our community and really talk through with them the services that they provide, but also how do we close those loops? How do we make sure those referrals are happening? And I don't think we would have been as successful as we have been with implementing our social determinants of health screenings if we hadn't really gotten buy-in from our staff at all levels. This was everyone from the person who answers the phone, our receptionist, to our referral coordinators, to our physicians and other healthcare providers. As far as challenges, I will go ahead and say the one that I don't think I've heard yet, but is I think one of those elephants in the room that Dr. Lakey was referring to earlier, and that is that this takes a lot of time. It takes time for the providers. It takes additional staff time either through social work staff or referral coordinators, patient navigators, and right now that time really isn't reimbursed well. And so in order for us to deepen our work, especially on that individual level, we really need to develop systems of funding streams that help support that. Whether that is that I can bill for doing social determinants of health screens such as food insecurity, or whether that is a per member per month for meeting quality measures related to social determinants of health. But we really do have to figure out how for frontline clinics who are dealing with high-risk populations, how to fund it. And then, as Celeste just said, the other big challenge, I think, is kind of not enough resources within our community. We have some areas of our community that have really robust resources. We are able to close the loop pretty well with food resources within our community. Housing is a whole nother ballgame where I have very limited resources to help families who are really struggling with food and with housing insecurity. And so really tightening the holes in that safety net. When I think of systems level changes as a pediatrician, I think one of the big shifts that I would like to see happen, not just within healthcare, but really within our entire social care network as well, is we are very good at wanting to fund programs or help children. And there seems to be a disconnect between understanding that the best way to support a child is actually to help support their parents. That kids need parents who are thriving, who are healthy. And that if we miss the boat and kind of we funnel a lot of money to kids programs, and I'm a pediatrician, obviously, this is my life's work. But if we don't recognize that really our unit of care is the family and the entire household, we are missing an opportunity to really generationally change social determinants of health. The other thing in the realm of being a pediatrician, I'll just speak for thinking about kids, is that when we talk about research and looking at social determinants of health programs and impact, we often are looking for short-term gains. Did we fix an asthma action plan, or did we improve an asthma symptom score? Did we lower a hemoglobin A1C? And we know that when we are looking at doing this in family settings and looking at children and outcomes, what we are really hoping to change are outcomes that they may have in 20, 30, 40, 50 years, right? We're looking to lengthen their lifespan and reduce their risks of chronic disease. And so we really need to be realistic about what measures we are going to be able to see, and how we are going to be able to track those things. I think it's great to look at process measures and to try to find some of those early outcome measures. But I think we need to understand that really that long-term goal is that prevention piece that has a very long arc. And unfortunately, as we fund things, we go through these 2 to 4 year cycles, right, of kind of what's in vogue and what we're funding. And really, I know that the impact of the work that we are doing in the clinic will be seen in our community somewhat in 6 months, but really we're talking about 6 years, 12 years. And so really challenging our policymakers to have that longer term vision of what addressing social determinants of health can do. I am happy to answer any questions about the nuts and bolts of what we do in the clinic, but I will stop there and we'll let Keegan talk, because I always learn something from Keegan every time she speaks.
Thank you so much. So that leads perfectly into Keegan Warren-Clum. Go ahead.
So I have to begin by apologizing for missing the first part of this afternoon's discussion. This morning started like any other for me, and then my laptop caught on fire. So I literally right under my hand. I disconnected everything, made sure that the immediate danger was past, and I realized this is actually a great metaphor for what so many people are experiencing at this point in time. I needed to be able to focus on healthcare, but a literal burning matter was taking precedent. Now, I'm fortunate because my laptop is managed by People's Community Clinic's amazing IT team, but the jokes are immediate. What happens when it's an attorney whose laptop catches on fire? I laughed along with him, but there's so much behind that question, because truly we do have a system that seeks to address these problems downstream, right, device issues, as well as to prevent them from happening. That system is the law. There are innumerable examples of the linkages between health and law. So consider, for example, that law was used to create separate and unequal systems of care for Black Americans and for white Americans, and that those consequences are evident in COVID-19 outcomes. Consider the way that facially neutral laws, such as those prohibiting the use of illicit drugs, are enforced inequitably across populations. Consider that many types of laws are actually meant to address health directly, like housing codes, but they're under-enforced or under-policed. Consider that the way in which courts interpret statutes and regulations can have an enormous effect on population health, such as the Supreme Court's 2012 decision that Medicaid expansion must be voluntary, or this month's decision to prohibit employers from discriminating against transgender and non-binary bodies. Now that, of course, occurred with the backdrop of a needless promulgation of a federal regulation that permits doctors to discriminate against those same persons, those who are transgender and non-binary, once they become patients. And finally, consider that there are myriad federal and state laws that are designed to improve health through disease prevention, anti-poverty programs, discrimination remediation, marketplace reform, and so on. So medical legal partnership is a means for integrating the system and expertise in the system into the delivery of healthcare. At its simplest, it means having a lawyer on site to address the health-harming legal needs of patients. These needs are often relatively straightforward and are encapsulated by the acronym iHealth, which is fleshed out somewhat on the handout that you were provided. It means that like a patient with a heart problem who is sent to a cardiologist for intervention, so too can a patient with a social problem be referred for intervention by a lawyer. Now, I say social problem deliberately because that which is remediable through legal intervention seldom manifests as a legal problem, at least for the average person. And this is a well-studied phenomenon in sociology. Health-harming legal needs are greater than non-lawyers typically think. And so, like a medical need, they require an expert to elucidate and to diagnose. And that's what starts to get at the real value and opportunity of having MLP as part of the toolkit. It's not the whole thing, it's just a piece of the toolkit. So yes, we want to think about co-location and data sharing and what they mean in terms of being able to easily close the referral loop in these systems. But just like having a medical specialist means more accurate standards of care and more nuanced diagnosing, so too does having a legal specialist mean more accurate integration of systems and in more nuanced fashion. This means having a lawyer available to do curbside consultations, for instance, perhaps on incorporating the Social Security Administration's disability standards into the patient's chart note. It means having a lawyer available who can review and collaborate on clinician letters for a patient seeking justification for workers' compensation claims, or perhaps having template letters for housing embedded in the EHR. And these issues matter not just because they are so often the source of frustration for physicians and other healthcare providers, but also because these systems routinely make use of medical records, whether they are drafted with the system in mind or not. Medical legal partnership also means transformation of practices that may not traditionally be driven by patient needs. And that's critical in this era of increasing focus on social determinants of health by the medical and public health systems, in this era of reforming the medical care payment system, and in this era of an emerging movement to train the next generation of health professionals in structural competency. And so MLP lawyers conduct trainings on health-harming legal needs for health professionals, for patients, and for communities, but too often they're left entirely out of medical schools. MLP lawyers add a valuable perspective to clinic policies. For example, my team incorporated the need for guardianship and especially its alternatives into the care team response for atypically functioning youth turning 18. Additionally, MLP lawyers participate in group health visits and address needs that start really where the social worker's license ends. So, for example, one of my staff attorneys was brought on board for the express purpose of helping pregnant persons experiencing domestic violence, because those conversations happen anyway, and it is a game changer to have someone on site who has the tools to actually solve the problem. Similarly, I am part of an integrated pain management team, and every one of the 8 or so different professionals who are part of that team would state unequivocally that there is immeasurable value in allowing each of us to tackle the portion of the needs of any given patient in a way that lets us stay in our professional lanes and also practice at the top of our various licenses. MLPs are also a ready answer when crisis strikes. During the pandemic, long before telehealth rules were changed or droplet clinic protocols were finalized, the governmental response was to adjust laws about eviction and unemployment and food insecurity, etc. But Texas did not issue utility cutoff protections, and so I organized a coalition of legal and medical organizations who petitioned for emergency rulemaking to address that health-harming legal need at the population level. After all, MLP is not just about serving the individual. It is a tailored tool for moving from patients to policy. So what are the challenges in the proliferation of MLP lawyers as part of the healthcare team? First, of course, as so many of my colleagues have mentioned, is the systemic challenge in the way that health is funded in the U.S. But we might point specifically to the need for a regular mechanism for paying MLP lawyers and other social care providers for the work that they are doing. And it cannot be that healthcare takes from underfunded CBOs. Importantly, I would echo what Dr. Smith said, longitudinal health benefit requires longitudinal funding. Second, if not co-location, there must be coordination. Patients referred into the community are by definition not those who could navigate the system on their own. And thus coordination must occur at the organizational level, but it also has to occur internally. There is a medical entity that I had hoped to work with, but that has faltered at establishing integrated legal care. They have an ongoing chorus of needing to internally regroup, and I've seen that elsewhere. But without those coordinated internal teams, integrated teams are a pipe dream. In other words, medical entities have to have their own house in order before they can engage in this work. That brings me to my third challenge, general counsel. And I know you're thinking, how can an attorney say that general counsel is a hurdle? But in the same way that you would not ask a neurosurgeon to operate on a heart, neither is it reasonable to think that general counsel understands the legal needs of patients. Their client is the entity. So to have a productive conversation about social services, whether through MLP or otherwise, medical entities need to look to their population health folks for leadership. So I have two final thoughts, and both are challenges that also re-highlight the opportunity that inheres in adding an MLP lawyer to the healthcare toolkit. There is, I think, sometimes insufficient appreciation that for all of the struggles with things like closing the loop, which again is built into MLP, a medical referral is not needed to access social services. And instead, that may actually seriously interfere with the very important work that's already being done. Now, I do not mean to suggest in any way that a full suite of social services shouldn't be integrated into the delivery of care, but I do propose that while we are still learning, MLP is a natural prototype for best practices. Now, this is because on some very real level, the transaction that occurs between attorney and client is not at all dissimilar from that which occurs between physician and patient. So lawyers use what we might call an electronic legal record. It functions at the encounter level and at the client level, just like an EHR. And as is noted in your materials, lawyers have long-standing systems for standard diagnosis of social problems, for measuring the acuity level of the need, and for indicating the short-term outcome of the intervention. We have embedded those legal fields into the EHR as well. And lastly, screening tools. These tools purport to screen for social determinants of health, but they very seldom do. Rather, they are screening for social risk factors, and that's fine, that's useful, that's actionable. But if you choose to hear nothing else from me, please hear this. I am begging you to stop carving out that which is legal as though law doesn't influence everything, because it does. It is the system that is creating the problem downstream. Law also offers a potential intervention for any given social need. But of course, you need that systems expert at the table for these opportunities to be obvious. Thank you.
Thank you, Keegan. Okay, so we will now take questions. As I had mentioned before, there's a little function at the bottom of your Zoom screen to under participants where you can raise your hand, and then we will take questions. Alternatively, you can chat it in and we'll be happy to address that.
See, Will Terry has the first question. If you can see that, Roxana, but.
Oh, thank you.
Go ahead.
I appreciate all the speakers and the insight and the information presented. One of my questions is for Celeste, and I was curious, in some of the documents, you mentioned kind of a phenomenon, a wrong pocket phenomenon, wherein some of the work of the social determinant of health intervention was being benefited elsewhere in either the healthcare or other public sectors. And I was wondering if you had any suggestions on how to track some of the social and societal benefits that come from doing this type of work that that can't really be tracked inside of a health system. If you had any kind of like off-the-cuff strategies or suggestions on how to track those kind of external benefits. Thank you.
Well, unfortunately, they're much more rudimentary than what we would typically do in our healthcare system. We require and actually use just basically Excel spreadsheets where we track our participation with various groups as well as our successes and improving clients. Again, because the majority of nonprofit agencies in our social area that we work with are unsophisticated, and therefore that's the best we can do. I'm sorry, but I hope that helps a little. They still work, even though they're old and tried and true.
I appreciate the info. Absolutely.
Do any of the other panelists have any comments on that or suggestions? Penny?
Well, because we are able to track it, we do learn about successes because we are not collecting anecdotal, we're collecting data. So we can tell how many referrals have been successful. And I've got the data of how many patients have been successfully helped.
Thank you. That's great. That's great. Anybody else want to raise their hand or chat in a question? I have a question while somebody raises their hand. I actually opening this up to any of the panelists, maybe just in terms of the whole issue of the longevity that was described. I think as a clinician, I certainly experienced it and experienced the frustration as well about the need to balance or create an understanding to inform others about the importance of the long-term effects of not just health outcomes, but social outcomes as well. So I'm wondering if you can give any suggestions to the audience and to other panelists about what you might think would be useful in terms of gathering information to share with others and be able to translate that into policy ultimately.
So I will take a stab at that, Roxanne. And I will say that I think it is helpful, at least in the world of pediatrics, that the evidence base that we have around adverse childhood experiences and their direct correlations to specific health outcomes in adulthood and shortened lifespan are helping to provide an evidence base. Because now that we have moved kind of past just the 10 discrete events that are considered adverse childhood experiences, some of which would also kind of overlap with what we consider to be social risk factors or social determinants of health, but really there's now an emerging literature about those what I would call adverse childhood environments, right? So racism, poverty, discrimination, different things like that, and their impacts on long-term health outcomes. And so while we may not be able to very quickly say this particular intervention impacted a child's risk to whether or not they're going to develop cardiovascular disease, if we can tie that this particular intervention reduced a child's experience or time in poverty or experience of witnessing domestic violence, or and use those specifics, then we have the literature base built out that reducing those things does improve long-term health, right? So I think finding those mid-proxy points, right, I think is really important there. And I don't know, I'm far enough into my career, maybe I won't be here in 20 years, but I'm really curious to be back in 20 years having this conversation, right? And seeing where we've come. What I try to remind myself of a lot, as that part frustrates me sometimes when talking even, I know there are probably a lot of funders on the call, but even looking at writing grant proposals and, here's all the measures we want in a year or in 18 months. And you think about, right, how challenging that is sometimes, and how difficult it is to really assess outcome in those short periods of time. But I think that as we start to connect those kind of dots between changing, we know that we have this evidence base here that these things are a risk factor, and kind of changing those risk factors. I hope that helps continue that work and the momentum to move it forward.
Thank you. That's helpful. Also, just to mention to everybody, there was a recent publication titled "Examining the Association Between ACEs, Childhood Poverty and Neglect, and Physical and Mental Health." Data was from Wisconsin and South Carolina. It was a really great article, and I think it also connects to broaden the ACEs to include poverty, which many of, if not all of our vulnerable populations have experienced or are experiencing.
May I add just one real quick thing, Dr. Cruz? Similar to what Dr. Gottlieb was talking about with the assistance trials, we are examining the impact of social determinants of health on uncontrolled diabetes, and we're trying to measure the true impact of whether addressing social determinants of health really changes, if we can really control or make an impact on diabetes and their A1Cs. We're also looking in our network on measuring mental health and doing PHQ-9s on all of the patients that we are screening to see if that's having an impact, if we can get a true outlook at the mental health and whether they need assistance, and trying to see what kind of impact that makes.
Thank you.
Roxana?
I might add.
Go ahead.
I think I got in just a second before you, Keegan. I would just add, I think you led, Roxana, it was a little bit of a leading question, because it occurred to me that, we're participating in that first cohort with TAC on trauma-informed care. And I think trauma-informed care and the approach to care is going to have a major impact in this area. Our challenge is going to be using a system to extract that data, because as all of our staff, and particularly our providers, are educated in trauma-informed care, they're a lot more attuned to the ACEs that you were referring, and how to follow up with that within our patients and within our community.
Thanks. Keegan, were you gonna throw in a comment?
I might add that I think that the medical outcomes are critical, right? But that there are, just like we're talking about kind of going upstream here to look at the ways that health exists outside the walls of our clinics and our hospitals, so too are there mechanisms for measuring that outside the traditional boundaries of medicine. And so I think that part of demonstrating respect for social services partners is to look at the research that is already being done in those fields that has long existed, long before healthcare came into this conversation. These organizations were doing work, and they were measuring it, and they were evaluating it. And so, again, I think it's part of demonstrating respect, and meaning that and demonstrating that healthcare means to be a partner in this is considering the ways that research already exists, and that those services are already being evaluated, even though that is not going to be in terms of A1C scores or whatever else, just to pick an example that I actually understand.
Thank you. I'm gonna call on Laura Rosen, who has her hand up. Unmute yourself. Oh, let me see. Unmute. Go ahead.
Can you hear me?
Yes, now we can. Go ahead.
Hi, I work at the medical school, and this question is to all of the presenters. Which staff are you all using to navigate patients to services? And it's a tremendous amount of time. And are those staff then following up with patients after their appointment once they've kind of referred them to a service, or is it kind of happening when the patient comes back in for another appointment just to see if they've connected with those services?
Who would like to answer that? I'm gonna assign it if you
I can go first. So we are a fully integrated system, and so we do not, insofar as the legal piece is concerned. For other services, we have community health workers, we have IBH clinical social workers, of course, but we have medical social workers as well. And then I know a couple of people mentioned the Episcopal Health Foundation CCHH effort, and People's Community Clinic has done that as well. And so we have some of those, but insofar as the services that are integrated, we don't need additional navigators, because we're just all sharing that same communication to begin with.
That's great. Anybody else want to give?
We have an LCSW who provides counseling, but also does patient navigation and resources, and then has typically 2 interns as well. I will say, as a nonprofit health clinic, finding kind of the free labor of students is a great thing, right, to take advantage of. And it actually has been a really great experience, because it has provided, so many of those students have stayed in our community, working for some of the community-based organizations, for example, that they developed relationships with while they were, at our clinic, learning and helping connect patients. We do have the goal in the next year to 18 months to add a couple of community health workers to do additional navigation as well.
Thank you. Thank you. I'm going to go to another question from Joelle Jung.
Hey, thanks. This is Joelle from Texas HHSC. I was wondering, just for all the panelists, I guess, that there's sort of this underlying assumption, I think, first of all, that there is a dedicated team member within the clinic or within the care team that can focus on providing these screenings, doing the referral coordination, doing a lot of that legwork. And that was definitely a theme throughout. I also can't help but notice, you know, these are FQHCs and or just clinics with a lot of support on this topic to begin with. So I was wondering if there's any perspectives or insight from the panelists on what that looks like though for those clinics, or just what it was like to even get on board from the beginning, since that's obviously an assumption that it's great for those that have the capacity for that or already have that leadership there, but that's definitely not the case necessarily throughout our state of Texas currently. And then there's also, you know, payers that might be providing this instead, but it sounds like all these examples are within the clinic and the care team within the clinic. So just any perspectives on that, either what it takes to really have a dedicated team member there, or what you would want to share to other organizations, either in a hospital setting or just other primary care clinic sort of settings.
I would like to say that it looks easy from the outside, but it is not easy. And as an FQHC, you might know that we juggle lots of job duties all of the time. And so our care coordinators who might juggle 150 patient panel to be able to add this to their task load, or eligibility staff who are doing actually certifying patients for you know, they're screening patients. They added this to their already existing job load. So it is something that was an expectation for them to take on. It was not something that they just didn't have anything to do. So it was something that they had to add on, and it was an expectation that they take it on. So it was not easy. It was something that was an expectation. But now that it's part of their workflow, they do it. We do screens. Only those individuals that have a need are actually referred for resources. That's what I wanted to say. So it's not easy, but it's an expectation, and we know that our patients at an FQHC are the majority, over half of our patients are uninsured and have needs. So we as a very team-oriented center, with of course mission-oriented, recognize that we want to take care of our patients, so we do it.
Thank you, Penny. And just to add on that, I think that the panelists here and all the staff that they represent at their respective health centers is because they're very mission driven for their patients and their populations. I mean, it all comes from why you do the work that you do. And as Penny said, that this is not easy. This is an add-on that everybody has taken on. There's not a reimbursement for doing screenings. We're trying to do the work anyway at our health centers, so this is more systematic. Very difficult task, but we're definitely in it for the right reasons, I think. Celeste, did you want to say something? I saw you unmuted.
I guess I was just looking, while we're sitting here, TAC pushed our 2018 finances to us to take a look at. And what struck me was we have very little cash on hand at any time. So to answer your question, it's a choice we made to devote and to provide resources and to run a very tight organization, so that we may have to worry from time to time whether all the paychecks are going to go out, but we're making sure that we're taking care of the patients. And that's first and foremost in our minds. And for us, those efforts are led by case management and CHWs. But I did want to point out, and I know Penny is in an organization that has the same things. The real challenges of this, sorry about my phone, the real challenges of this for us are serving our behavioral health patients. And we have a very specific position called an integrated nurse, who it does take individuals that are specifically trained on how to follow up with patients. But those individuals are our most challenging to really address their needs. So just throw that out there.
Thank you. Yes, Dr. Smith.
I would just add to be quite honest, so I have spent Food insecurity is where I've spent a whole lot of time over the last few years, and I've spent a lot of that time educating other healthcare providers, both in my own local community and across the state, about its impact and the value of screening. And the reality is that in many sectors that aren't FQHCs or community-based clinics, that are more traditional private practice settings, it's just not happening. Right? I mean, Dr. Gottlieb showed us that data of what at least patients are perceiving as to whether they're being screened or not. And I think it's a combination of two things. I think they're, quite frankly, among many providers who are not taking care of significant either uninsured or Medicare populations, there is a misconception that it's not a problem among their patient population. When we really do have evidence that, 1 in 4 kids in my community is food insecure. You can't walk into a school classroom or watch a kid's soccer team, right, without there being kids who are food insecure. And so I know that my colleagues who are seeing kids in private practice, every day they're seeing kids who are food insecure. They just don't know it yet, right? Because they haven't been asking. And then the flip side to that is that there is really the struggle. Many of them are starting to kind of awaken to that, but there is this struggle of, but I don't have those resources. I don't have a social worker I can call. I don't have, a network set up to help address this problem. And so there's a real fear among physicians and healthcare providers, I think, of asking questions we don't know the answers to, right? Or opening up something that we don't have an intervention for. And so one of the things that we've done as part of our community-centered health homework on at least the local level is trying to build out those resources and be able to share them with the other healthcare providers in our community so that they know where they can go to and create relationships between food pantries and our food bank. And benefits assistance, right? People who can help enroll in SNAP and WIC, and those other healthcare providers who don't have those things internally, right, within their own system.
Thank you. And I see Dr. David Lakey has a question.
Sure. First, turn on my video. Thank you all for being here today. Again, I think it was a great discussion. A specific question for medical legal partnership. So Kagan, to talk to you. I've heard you present several times, and always impressed that this seems to be something obvious that FQHCs and others should do. And I know you've been working with other institutions trying to help them stand up medical legal partnership, but it still seems like it's in some ways it's still rare. I guess, is that a false impression? Kind of where are we in the state in getting that more universal? And if it is, that impression is right, that it's still a lot of room to expand, what kind of pushback are you getting? Why are the critics saying, or they don't bring it up? Or is it, why are we still in that gap of not implementing that in the way that seems possible?
Thank you. Yeah, your observation is right on. There are a limited number of MLPs in Texas, and all of them are in the major cities. They're split between clinics and children's hospitals. We don't see a lot of activity in hospitals that serve general populations and particularly adult populations. I think that gets at some of the challenges that were mentioned earlier. So why do I think it's rare? I think so much of it is that until you have experienced what it is to have a lawyer who's on your side, who's part of the team that you're working on, it sounds like an abstract goal that might be nice, but it's hard to fully appreciate that it's not just about individual referrals, that there is so much more that you can accomplish through that co-location and collaboration. And so I think it's just a lack of experience. I also think that that's why it's critical that we are training medical students and residents in how to collaborate, because I think that's the other challenge, is that for for healthcare administrators or for people who are making decisions on the ground in healthcare entities, if they've never been taught to work with other persons, why would they think that that's a step that's and worth and going to be worth spending money on? So I actually think that's the greatest thing we could do. And the other thing that we might have a conversation about is whether there should be some kind of encouragement, some kind of incentive for doing this kind of work. In New York and in Georgia, it is defined in state law what a medical legal partnership is. There's lots of reasons to maybe push back against that, and that there's only 2 states that have taken that approach. But I think if we had clearer standards at the state level, clearer guidance for whatever kind of integrated care delivery teams we're going to have, that that it would both increase the amount of information in this area as well as incentivize actually doing this work.
So quick follow-up, if I may. Can you talk about how these are funded? The different funding mechanisms, and then also you started to go down this pathway, but what could the state do in order to really facilitate that?
That's a kind of a big question. I think there's several levels of things, right? Like you could start by just defining what it is, so that you're actually increasing the information that's out there, so that there are more people who are laying eyes on this concept. And financial incentives work. They are the ways we direct FQs, for instance, to do other work. They're the ways that we tell hospitals that they're going to do their community health, needs assessments. We can't actually direct that you're going to engage in a certain amount of looking at health as broader than that biomedical perspective. So I think being aware that the system itself, our regulatory mechanisms, the same way we control other things, could be used to incentivize this behavior as well.
And the funding mechanism part of that question, currently, how do you see MLPs being funded across the state?
So my pushback is always that it shouldn't come from the legal services community. On a federal level, we haven't seen an increase in those funds since the Reagan administration. And on the individual state levels, that number there's not a whole lot of change. So I think we have to look at other ways that we are spending this money, whether we address these needs or not, and look at smarter allocations, look at less downstream response to problems once they've happened, and put those dollars in prevention, put those dollars in our communities. Which is a little bit generic, but I think there's some conversations that we're not having in very open and honest ways about why I would default to responding to the bad thing once it's occurred instead of preventing it from happening.
But it sounded like in the past that philanthropic organizations were part of that startup. Is that a misrepresentation?
That's correct, but I don't think we should be asking our philanthropies to stand in for poor governmental prioritization.
Thank you.
I see Octavio Martinez has a question.
Thank you. Hopefully my internet connection this time won't fail me. Question for all the panelists though. Thinking about systems level change that you've all been talking about, but operationalizing that into policy. At the regional level, at the local level, many solutions are identified that you say, oh, policy level, we could just change this. But then at the state or federal level, there seems to be a disconnect because the policy then becomes much more about party or becomes very conservative in Texas, even federally, and it really doesn't connect to what's really needed and happening at the regional or local level. What role do you see yourselves playing to be able to help us make that connection and actually work synergistically and in unison?
Who would like to answer that?
I can only see, this is Penny, I only see if we can get TAC to help us, our Primary Care Association, to help at the state, which might help at the federal level, because this is a huge effort. It takes a lot of advocacy to get anything that big, unless, yeah, that's all I can consider.
Okay, well, we have our executive director on the call, so she may be able to help us out. Dr. Smith?
Oh, well, I was just going to add that I think that we need to think creatively and thoughtfully about non-legislative solutions and policy that we can advocate for at both the state and federal levels, because, as Dr. Martinez mentioned, things get really mucky in the legislature, right, and can become very politicized. So, for example, one of the things that the Texas Pediatric Society Committee on Nutrition and Obesity, actually Nutrition and Wellness, I'm sorry, we renamed ourselves, one of their co-chairs and I earlier this year submitted a request to HHSC to have food insecurity screening covered as a Medicaid covered benefit. There are administrative processes for some of these changes to happen that don't have to get bogged down in politics and really can focus on what the good is for the children or the patients that are being served, and how our state institutions can work better to serve those people.
Does anybody
Excellent
else?
point. Thank you.
All right, Elena Marks has a question.
Thanks. I am curious as to whether any of your organizations has entered into a contract with a payer, be it a Medicaid MCO or other payer, that uses any kind of methodology that would allow you to do something to get paid other than just see patients in the clinic. So for example, a payment methodology that would allow you to devote some resources to food insecurity or another social determinant issue. And if so, then tell me. And if not, I'm curious as to whether you would be willing and interested in something like that, an opportunity like that.
Any of the panelists who would like to address that?
This is Celeste. Oh, you
ahead,
sure,
Celeste.
Penny? Okay. Elena, we have not. We're always intrigued by looking at new approaches. Our biggest, it does take quite a bit to change a ship that's been working towards a wraparound payment, and that's how we receive our money. So our organization for many years has been organized in that fashion. But I've always believed that value-based payment is the direction that we'll need to go. And I know there are lots of pioneers out there that have been incredibly successful. So we're always very interested in that, because I believe until we get to that, we're always going to be struggling with this question.
Thank you. Penny?
And I would say real quickly that we have a couple of Medicare ACOs that we're participating in that does compensate us. And we have just a few private plans that are paying with quality incentives. I don't know that they're not truly addressing social determinants of health, but we would be very interested in participating in such an agreement.
Keegan?
I would echo that. We would, of course, be interested. And there are some examples to look towards. We have not done that yet, but after, I'm going to get this wrong, I think it was Hurricane Matthew in North Carolina about a little over 10 years ago, Blue Cross Blue Shield provided several $100,000 to legal aid, right? Because the outcomes of the health outcomes of the disaster that was that hurricane were very predictably going to have impact on the healthcare system, and they thought that it was a better investment to assist people with preventing those needs before they became medical problems. So we do have models to look to. Indiana saw this more recently with their third-party payers, and then the other mechanism, and this will follow up a little bit, I think, on what Dr. Lakey was pushing at, is North Carolina recently said if you want an MCO contract, then there are certain things that you must do in order to be considered. MLP was one of those. and put that on the third party payer, because I think absolutely until we put some substance behind this notion of value-based care, it's just talk. We're just talking about how it would be nice, but we're not actually doing it.
Thank you. And Dr. Lakey has indicated he has another question.
Thanks. So it was noted at the very beginning that there's a variety of companies that have a electronic solution or a tool to assist entities like yours in this whole realm, whether it's matching patients with services or that have data related to social determinants of health that they would provide at a cost to entities. What kind of experience have you had with those type of companies, and just kind of thoughts related? Is that part of the solution? Is it a big part or a small part? You know, how do those entities play into what you see on the front lines and what you need in order to address these issues?
Would anybody like to?
So I'm not sure if that's the same thing like the Unite Us that you're talking about, Dr. Leakey.
Yeah, those and a variety of the others, yes.
Yeah, so we are using Signify Health, Tab Health, Signify Health, and that's the platform that we are connecting the other 34 social service agencies in United Way in our community. And it is very helpful for us. It's a way for everybody to be held accountable to make the referrals and to ensure that the patient's needs are being taken care of. It's how we're getting data out of the system to know that in the last year we've made there were 2,915 needs identified, 977 referrals made. It tells us which organizations are not meeting that need, who to follow up with, what our current the top 5 needs are, who's referring the most, who's accepting the most referrals. So that's what we are looking at, and that's a way for us to track and follow up with those organizations who are not helping our patients. So it's very helpful for us.
Does anybody else have an example that they want to share?
But Valerie, are you using anything like that?
We are not, and I will be honest, as a small clinic, I am convinced what we need to be able to use that is the buy-in from one of our 2 large hospital systems, right? That I don't know that we as a clinic that sees, 6,000 kids a year can drive enough change within those social service organizations, right? As I think it was Dr. Gottlieb earlier was talking about all of the process change that involves for them. What I really would love to see is for us to tackle that issue kind of regionally so that all of our healthcare systems were potentially using the same platform. I think that could really revolutionize. It would also allow us to share that data among hospital systems, not patient specific necessarily, but looking at is what Krista is seeing, also what UT Health is seeing, also what Family Circle of Care, right, and our FQHCs and smaller clinics are seeing. I don't have a solution to how to make that happen, though. You know much more powerful people than I do, so maybe you can help move that forward for me.
Thanks.
Thank you. Dr. Octavio Martinez has another question. Go ahead.
Thank you, Dr. Cruz. I was fascinated in reading the case studies, and one of the things that I haven't heard from the panelists in all the different ways you guys are approaching this, but from the work we've done at the Hogg Foundation, workforce is a rate limiting factor, but it's not just a numbers game, right? Also, it's actually the skill set that these providers need to have, and not just physicians, but also our nurses, social workers, psychologists, and so forth and so on. From your perspective, are you seeing that our educational systems, our programs that are training our professionals, are they instilling the right types of skill sets that you find you need to be able to, in fact, have an integrated care system?
Who would like to answer that? I think that in health center world, we try for integrated systems, but by and large, I also remember from my days not so long ago in the health centers, we have to train them as they come in. and develop those integrated systems and demonstrate how team-based care actually does work. And really, that's the only way we'll be able to achieve the goals that we set out when we have such complex patient populations. Celeste, were you wanting to provide?
I guess I would just add, Roxana, that what we found is if we hire individuals that don't have that skill set, they don't last. Because to work in our environment, they have to have the passion and the mission to do those type of things. Otherwise, we aren't really helping our patients. So I didn't answer your question, which was a fairly sticky one, as to whether the universities are providing the proper education. All I can say is without it, they won't work well in our environment.
That's very interesting, Celeste. Thank you so much, because also what we've heard from some of our grantees is the capacity to be able to retrain them at times can be also quite significant. And so us in the educational field are rather falling short in providing you, who are on the front lines, the right type of provider with the right type of skill sets. And that also includes cultural linguistic competency, person-centered care, team-based care, and all the other things each one of you has also mentioned. So very interested in that because from the workforce standpoint issue.
Do any other comments from the panelists? Maybe anybody else want to ask a question or chat in a question from the audience?
Roxanne, I have a question. This is Eileen.
Oh, hey.
And this is, I think this is an overarching theme for the meeting that I wanted us to dig into, and I think it falls in that elephants in the room a little bit category. So several panelists talked about the need to understand that these outcomes have to be seen on a longer time horizon. These are long-term outcomes in terms of the health outcomes. Also need to respect and value those the social outcomes as important in and of themselves. So understanding that there may be some measurable health outcomes, but they're going to be few and far between that are going to show up in that 1 to 2 year time horizon. So with that in mind, I'm also hearing that we want to shift from, this is Lena Marks, from, it's about health, not just healthcare, and this idea of that we want to be purchasing health, whatever that takes, not just the actual health, the healthcare services that traditionally we've purchased. So that looking at the existing funding that's available to healthcare and shifting it to whatever needs to be paid for in order to create the health. So given that would require seeing some health outcomes in a relatively short time frame, because seeing it 12 years out may not work for the healthcare payers, and we're going to have some conversation with healthcare payers later. I want to just put this out here right now as I think one of the central challenges, who is going to pay for this care, this social care, when the health outcomes we know are not going to be seen for many years down the road, and we may see the social care outcomes but not the healthcare outcomes. So the challenge of looking to healthcare to pay for that, or the existing funding for healthcare, I think is an essential rub here. So I want to put that out there and see what thoughts folks had on reactions to that.
So anybody from the panelists, what I'm hearing you say or ask to discuss is who is going to invest in the commitment to improving health, right? But health being the bigger picture, not just health outcomes, health including social determinants of health, including well-being.
Yeah, and how do we gauge that conversation that it's not just shifting to value-based care is a temporary, and I think maybe Keegan, someone had said this, like that's a short term, or it's not the end that's not going to get us to the final finish line in terms of covering these costs of social care to create the health that we want. So any thoughts from the panelists about that are thinking about how do we cover these costs knowing that they're not going to have short-term health outcomes?
So who's going to invest in this? Because that's really what we're talking about. You're not going to see them for a long time, but you have to put something into it now, because otherwise we'll never get there.
Right, and perhaps vice versa is how can we talk about the outcomes that we want to achieve honestly?
Well, I'm going to have to say that every time I write grants, so I know that Dr. Smith said something similar to this, and you just have to keep going until some big funder or some insurance company comes along and says we're going to invest in it. So every time I write a grant, some of my outcomes have to do with what's the impact of the project. Part of my project or my outcome has to do with demonstrating the impact of making a difference on the social determinants of health. I mean, I'm always looking for a way to fund some of our work. So that's part of the solution, short-term wise, is to get us one step closer until we demonstrate that what we're doing is making a difference. And I'm always writing grants, and whether it's to one foundation or to another or to the state, my outcomes have to do with intervening and demonstrating that we can impact the social determinants of health to improve health outcomes. And so we get a little bit of funding, and I know that that's only going to make a difference here, but if we can get some real results and demonstrate through research, I mean, I'll be honest, I'm working with Siren. They're going to do a little mini research project here. Any fact I can get to demonstrate positive outcomes will help me along until finally somebody breaks the bank and the health insurance or makes a big difference. Health insurance plans, the state, like you've talked about, public policy changes, and we get a real difference, and it becomes part of quality incentives. It's part of the value-based care contracts. But that's what I can do at my level.
Keegan?
Yeah, I mean, at the risk of opposing a naive suggestion, who's paying for it now? Because we act like this is kind of zero sum. Or that we have to come up with money to pay for a different result, except we're paying for the bad result. And so much of the question, I think, is who is paying for that bad result? So right now on my caseload, I have 2 different folks that before the end of the year, by the time I'm finished using a legal intervention to remediate very, very serious medical problems, both of our major hospital organizations are going to see an influx of Medicaid dollars in the hundreds of thousands for each of these folks. But somebody paid for those surgeries and all of the medical interventions that have already happened before we took another approach. And so I don't mean to sound naive, but we're already paying for it. This is a matter of shifting those dollars, and I don't see where that is actually where that should be as great a challenge as we act like it is. And I can prove those outcomes, by the way. I have a box for it. I have a field for it, right? So,
Dr. Smith, were you going to make a comment?
Well, I was just going to say, page 1 of the pre-read that Eileen sent out has the graph of what we as a country invest in social care versus what we as a nation invest in healthcare, and how disproportionate it is to every other developed country on this planet. I know that may not be the popular answer, especially in Texas at this moment, but I don't see another way for philanthropy, churches, the private social safety net cannot meet that challenge. We don't have the ability to do it independent of significant investment from the government.
Do we have any last comments? We're coming up on, or questions. One last question. Okay, Dorothy Mandel.
Hi, this is great. And with that said, that also we need to stop thinking about this as the wrong pocket because it's the taxpayer's pocket eventually. I appreciate that, and I appreciate the recentering on that. I would like to bring it back around because, you know, Dr. Smith, I also work in the pediatric in that realm. Can we go back to this two-generational issue a little bit and talk about this? Because I do think that this hits our social services as well as our pediatric providers in a very special way. Is who's the patient, who's receiving the services, and therefore in which way are they going to get paid for? And so Valerie and Keegan, because Keegan, I know that you've been working at People's in the pediatric clinic as well. Can you guys talk a little bit about that and how you've navigated this payment process of who's actually receiving the social services is not your patient, it's the parents who are receiving the social services, and how that gets balanced and navigated?
And I think part of my answer is not navigating it very well. Unfortunately, Dorothy, for a lot of our families, I do think that one of the things that we as a clinic have determined is, for example, when we do a Medicaid eligibility for a child, we actually look at everything that family is eligible for as a household, right? So can I get mom enrolled in Healthy Texas Women so that she then may have access to some postpartum care related to postpartum depression or issues like that, that I think are important. There is, I think, an opportunity for some more of that coming in at least for the most at-risk children in our state, and that's through some funding that will be available through the Family First Federal Prevention Services Act, which for the first time will allow prevention funding to be used for parents for substance use disorder treatment and mental health treatments, as well as in-home parenting supports for families who are at risk of children entering foster care. But that is, I mean, we are taking, if we're using the stream, that's the family that's already midstream and trying to pull them out, as opposed to really investing in those true primary prevention funding. I will say the state of Texas is actually far ahead of many other states in funding primary prevention. It is just that we are such a large state that it is insufficient for the demand that we have.
Thank you. Keegan, do you want to give any comments?
Yeah, I mean, I might second that it's case by case. I'm not sure that in terms of who the beneficiary is, but for us, we have relatively clear rules about who can be a client and who can't, right? It's minors cannot generally enter into a professional contract, and so it tends to center around the parents, but there are exceptions to that, certainly. So within our systems, we use those guidelines. But on the health side, and I think this is also indicative of a technological challenge, is that it's not just parent versus child. Sometimes there's other children. You know, we've had children referred because they're living in moldy housing, but you're actually impacting the health of that entire family, not just that single child that received the referral. So, but technologically, actually inputting that data, I can tell you what the outcome was. We got that family into a different apartment. Right, problem solved, but there's also a technological challenge, I think, just purely in whose record should reflect that information. And so it just tends to be case by case. What does it feel like amongst all of the members of the care team? Who was the beneficiary? The other thing I would say is that sometimes we don't interact with the patient. Sometimes we only are having like teaching moments, these consultations with clinicians. And so we may or may not know the patient's name. We may just be seeking to improve the professional education and on a particular field. And so that just really multiplies kind of the challenge that you're talking about in terms of who's benefiting. There are so many more beneficiaries from an integrated approach than just a singular patient. So I think there's a lot of opportunity there.
Thank you. So we are at time. This has been a fabulous group of panelists and great questions and a lot of wonderful discussion. We'll now have a 15-minute break. Please plan to return by 3 p.m. for our second panel of the meeting on healthcare payers' perspectives. And this is to thank a great panel and Eileen Neem for putting it together, and Dr. Lakey and Elena Marks for letting us have this great forum. So